everyone. I'm Claudia Diaconu, and this is my colleague Theodor Voiosu, and we are both gastroenterologists working at Colentina Clinical Hospital in Bucharest, Romania. On behalf of all of our co-authors, we would like to thank the editors of Endoscopy for the opportunity to share with you the main aspects of our recently published paper entitled "A Simple Clinical Score Can Stratify the Risk of Procedure-Related Adverse Events in ERCP Procedures with Trainee Involvement."
Training for advanced endoscopic procedures, such as ERCP, remains an important challenge for most training programs, as real-life data shows that many endoscopists in training fail to reach the required procedure volume or the predefined competence threshold during their training periods. This data has driven the current paradigm change, with most expert societies advocating for a structured, competence-based approach rather than the old caseload-based threshold for competence assessment and credentialing.
Speaking from experience, as an advanced endoscopy fellow, training in ERCP differs from training in endoscopy in general because it is more technically demanding and it requires considerable manual dexterity. Importantly, this is a procedure with a high risk for adverse events, even in expert hands.
We based this current study on our previously published paper, which also came out in endoscopy a couple of years back, on the impact of trainee involvement on the outcome of ERCP procedures. This initial study showed that procedures carried out in a teaching setting can be performed safely and do not carry an increased risk for the patient if a trainee is involved. However, in an effort to better tailor the training environment, we proposed a pre-procedural score to identify patients who might be at a higher risk of developing procedure-related adverse events if their procedure took place in a training environment.
What did we do in the current study? We performed a prospective, multicenter, investigator-driven cohort study that included 5 training centers. We gathered clinical and technical data regarding the patients and the ERCP procedures that imply a trainee, with the additional control group of patients treated by expert endoscopists. The main outcome of our study was the rate of adverse events in a training environment in low and high risk patients, as stratified using our proposed clinical score.
Briefly, our current study included a total of 1,200 ERCPs, of which almost one-third included trainee involvement. The study was performed by 11 trainers and 10 trainees. Using a simple risk score consisting of bilirubin level, procedure difficulty, history of a previously attempted ERCP, and the presence of a native papilla anatomy, we classified the procedures as either low or high risk for training ERCPs. The score showed a very high negative predictive value for adverse events, proving very useful for predicting safe procedures. So that means that procedures were not followed by any sort of adverse event, even though trainees were involved in these procedures. Also, interestingly, a superior trainee performance, as assessed by a validated tool such as the TSAT score, was also correlated with better procedural outcomes.
Going forward, we aim to validate these findings in a new study, checking whether individualized ERCP training by matching patient and operator risk profiles will result in a lower rate of adverse events in a training setting.
Finally, we would like to thank all of our colleagues from the participating centers for their diligent research effort, particularly since much of the study took place during the COVID pandemic and training did not stop for the pandemic. We would like to invite you all to read the full article in Endoscopy, and we thank you for your attention.